David mentioned perhaps a survival advantage about anxiety. We wouldn't be surviving as a species if we didn't have some mechanisms for threat, awareness, fear, and anxiety. It is, in an evolutionary sense, something that we need. So anxiety is normal, but anxiety disorders are not. I've got lots of conflicts of interest, unfortunately, and maybe that's a good thing. They all cancel each other out. But I've had fees from just about everybody in my career. I'm going to focus more on social anxiety, panic disorder, and generalized anxiety disorder. Some of the things I talk about might also apply to obsessive compulsive disorder, but it's really a presentation all of its own. PTSD and its all its varieties are also a form of anxiety disorder, but again, they really only do justice in a presentation all of their own. And a lot of what you talk about in these more mainstream anxiety disorders probably doesn't always apply so much to PTSD. I'm doing very briefly, I mean, it's a very brief rule of thumb. In panic disorder, people worry about their panic and how it will impact on them. Social anxiety disorder, people worry about how they will be judged. And in generalized anxiety disorder, people worry about everything and nothing across a wide variety of contexts. Very, very brief sort of epidemiology. Mostly these are disorders of younger people. Up to about the age of mid-30s is when most anxiety disorders have their onset. Women more often report them, but the actual sex difference is probably fairly close. It's just underreported by males. Western countries, they are more often reported than in other cultures. But probably the rate is pretty much the same. It's a reporting bias. Affects about 1 in every 7 adults in any given year. That's a lot of people. Some cultural presentations can be difficult to recognise. In my own experience working as a registrar with Indigenous people, found it very difficult at times to read their affect, how they were communicating emotionally, but also with their language of anxiety. There are a wide variety of cultural differences of presentation of all psychiatric disorders, really. I won't go into that too much. And of course, we see a lot of comorbidity with anxiety disorders, mood disorders and substance abuse disorders in particular. Anxiety can also be the presenting phenomena, and if you like, all the prodrome of schizophrenia, or the early presenting phenomena of relapse of a psychotic illness. So, social anxiety disorder is probably the most prevalent one. And panic disorder, agoraphobia down the other end of the scale, but they're all fairly common conditions. As I said, presenting after the age of 40 is fairly uncommon, and if an anxiety disorder presents after that age, you've probably got to be thinking about other causes, particularly substance use issues, whether it's perhaps a phenomenon of a major depressive disorder whose rates do increase as people get older, whether we're looking at other organic causes as well, or, as I've seen from time to time, about once a year, Alzheimer's disease presenting in a 50-year-old with the initial symptoms of an anxiety or a depressive syndrome, with the cognitive consequences of the Alzheimer's disease presenting sometimes up to 4 or 5 years later. So social anxiety disorder has its origins earlier, in early adolescence, agoraphobia a little bit later, and then into the 30s, up to the 30s, panic disorder and generalized anxiety disorder. Who gets treatment? Hardly anyone does. Yourselves as general practitioners do the bulk of it. And as I said, psychiatrists not so much. I think we could all do a bit better in how we do go about recognising people who need treatment and applying it. So they're called the high prevalence disorders. They're the things that, as a registrar, I hardly ever saw. Working in public hospitals, I saw 90% people with schizophrenia and the other 10% with severe personality disorders. People with these highly prevalent disorders never made it to registrar training. You're just not trained, you just don't see these people. They get seen in general practice in the main. You see a lot of people with anxiety syndromes like these. Most of those people who do seek help actually go to their GP first. Some surveys would suggest that very few people actually get adequate care. A lot get some sort of care, but probably inadequate. And as I said, as a psychiatrist, I only see a tiny minority, and generally at the most severe end of the spectrum, by which stage many of them are almost treatment resistant. And I can think of some of the very severe generalized anxiety disorder patients I've seen. By the time they get to me and they've tried multiple courses of treatment, there's almost nothing that can be done that's effective at that point. The level of disability, the probable biological changes in brain as a result of that chronic anxiety, the social decline, the social upheaval, the loss of relationships and work, it's just designed at that point to maintain the anxiety disorder. The etiological sort of things are great when you're educating patients and talking about these things. It's I mentioned earlier that in an evolutionary sense, anxiety has a role. So clearly there's a genetic basis to a lot of it. And anxiety disorders as well must clearly have a genetic basis, particularly in panic disorder. There's a strong genetic basis, particularly confirmed during identical twin studies. There are also it's clearly the biopsychosocial model, which you can apply to everything in medicine. And there are all sorts of contributions from all over the place. Not forgetting that if you have a vulnerability to one anxiety disorder, 50% of the time, you're going to have a second one. So these sort of polymorphic anxiety presentations are very common. And I look at the letters I write back to referring GPs from time to time, and I kind of write a diagnostic statement like that, saying basically a sort of a polymorphic anxiety disorder, with features of generalized anxiety disorder and social anxiety disorder, or something like that. So people's anxiety syndromes are perhaps generally probably present more polymorphic than we think. It's a very costly disorder. Like all psychiatric disorders, they all have their social costs and their health costs. Very, very costly. In terms of days of work lost, people, the more severe the anxiety, clearly, the more time people take off. Or, like many of the people that get to the stage of seeing me, they're not working at all. And they are social security dependent and or financially destitute. All the other costs that surround health are enormous in psychiatry, in particular, and the same applies to anxiety disorders. So fear and anxiety are all the same, but kind of different. Fear is more of an immediate alarm reaction to present danger. A panic attack has some similarities to that, but there is no present or proximal danger, although there may be triggering events. And anxiety has more of a connotation of mood to it, or a negative, anxious mood state, and a range of physical symptoms. And it does tend to have some of those flight and fright phenomena as well, but tends to be a more persistent pathological state. So what's a disorder? So as I said earlier, being anxious by itself isn't a disorder, and it may be entirely appropriate and not only that, protective. But if it becomes pervasive or repetitive, with that some threat, some sort of a threat that's physical, social, financial, or other that accompanies the anxiety, it's obviously a disorder. Many people too become anxious about anxiety itself. So in panic disorder, for instance, the panic disorder is the panic attack is is what you need for diagnosis, but the anticipatory anxiety about having a panic attack can become just as disabling, and sometimes more disabling than the panic attacks themselves. And of course, if people are using avoidance strategies, which are very effective short term, then they become doubly disabled because they have they become disconnected from society. Avoidance, it's a bit like insomnia, I reckon. It's one of the hardest things to treat anywhere. Treating insomnia, treating avoidance, they're really difficult things to overcome. And I said avoidance works really well. You avoid something, you feel better pretty quickly. And it doesn't take long for very anxious people to realise that if they avoid the source of their anxiety, they have something they can use repeatedly and to their advantage initially, every time. But of course, if that becomes a preferred strategy to manage threat and anxiety, you are then becoming disabled. If you're agoraphobic because of panic attacks and you never leave your house, you have very few symptoms at all. You can rely on the internet or other people to look after you and bring you things, then you are not actually experiencing any symptoms, but you are completely disabled. Trying to get people to sidestep around their avoidance is a key to treatment, particularly in persistent anxiety disorders, and probably one of the hardest things to do. Avoidance also extends to avoiding treatment, particularly if you're agoraphobic. You can stay where you are and there's no threat. To actually go and get treatment, see someone face to face becomes a threat, so you avoid that too. So anxiety isn't all that bad until it is, and then it's terrible. You know, a little bit of moderate anxiety makes us alert and improves performance. And sports psychologists tap into this all the time. And even very high levels of anxiety acutely can be very appropriate, particularly when there is a possible threat and a very real danger. And it does enable a very rapid action, which has a survival advantage. But of course, extreme and persistent anxiety inhibits cognition, and therefore your ability to think and problem solve and plan and sort and rank and order your life becomes more and more impaired. So unhelpful thinking patterns then intrude on top of that and become further entrenched. Sure, that's so big. How treatable? Well, these are disorders that are difficult to extinguish. And so aiming for cure or complete remission is probably unrealistic in many people. Add to that, despite the availability of treatments, they take a very long time to work. You think about very long time frames in the treatment of anxiety disorders, much, much longer than you would see treating more purely depressive syndromes. That next line says anxiety disorders are highly treatable but resistant to extinction. Need to have a formatting issue because the small slide was fine. The big slides come up big.
Okay.
I scroll up and down there.
Yeah, I think it's just those two slides.
Okay, just those two slides. One thing I say to people is, well, the aim of treatment here is to reduce your symptoms. You'll still have an anxiety disorder in the end of it, but if we can reduce your symptoms by 50%, we shift you from a position of where you're not coping at all to where you probably are coping most of the time with effort. So I give a kind of a realistic and hopefully not too pessimistic goal for people, something that they can think, yeah, that's kind of believable, I think I can get there. By the time they get to treatment, they've had their symptoms for long periods too. So they are in an entrenched pessimistic state. And if you give an overly rosy opinion about how you're going to treat them, most of them won't believe you and you probably won't engage with them. The broad treatment aims are to reduce emotional sensitivity, reduce the anxiety itself, reduce the anticipatory anxiety about what outcomes they may be trying to what they may be worrying about, and reduce the avoidance behaviours. And as I said at the top, broad treatment aims are easier said than done. These are conditions that require a dedicated approach from the patient, a dedicated approach from psychologists generally, and a long-term approach from the medical professional. What do we do when people are really acutely anxious? And it's interesting, but just coming to care, if they can get there, actually helps. People getting to the waiting room actually starts the process and does help. People come with positive expectation by the time they get there, if they can get there. So they are already, in a sense, on the journey. Certainly in acute anxiety, when you see people, and occasionally this happens in my consulting rooms, the simplest trick that I do is breathing control, talking through breathing exercises, breathing in for 4 seconds and showing them how to do it and actually modelling it in front of them, holding for 2 seconds and breathing out for 6. It's not breathing deeply. You don't want to make people develop hypocapnia. You want to just keep people controlled and managing their anxiety. And then asking those sort of leading questions is very useful. It's clear that someone's anxious. I mean, it's a diagnosis in the waiting room, but you can show your interest and you can start to get that history about what it feels like for the person to be anxious, what's causing them to be anxious, what do they fear, and what does anxiety stop them doing, all parts of the history. And then in the consulting room, many people are quickly reassured once you take some interest in them. Once you show a little bit of professional interest and start delving into their background, people are already starting to feel like they've been understood and starting to feel like that they may have an approach to treatment. You may have actually seen people at their worst at that time. These are fluctuating conditions, even though they're fairly chronic and persistent, but you may actually see people actually really well at times complaining of anxiety disorder. So history is key, not the presentation, obviously. And everyone wants a rapid response to anxiety. We spend our lives making things certain around us so we don't feel anxious, so we don't feel uncertain. But of course, one of the things you have to tell patients about anxiety disorders, this is a long-term approach. Nothing much will be usefully gained in the short term. So saying that, benzodiazepines and other little treatment tricks can be very useful in giving people perhaps some sort of sense of acute relief, but also starting that therapeutic process of engagement into that longer term journey of anxiety management. So this is what you do at every consultation, what I probably do as well. Therapeutic relationship has been established. We're doing a sort of a diagnostic assessment and considering differentials. I mean, sometimes these things happen instantly. I mean, you see people in the waiting room, you recognize a pattern immediately. You're already going down that pathway in your thinking and your history taking. We're identifying comorbidities, particularly an issue to question about in anxiety disorders, and particularly with alcohol and alcohol-related disorders as being both a consequence and a cause of anxiety disorders. We're going down the pathway of thinking about treatment planning even before we finish the history. We're assessing lifestyle and other psychosocial issues. And we're also kind of making some judgments about how well this patient might be able to embark on some of their own management with a bit of guidance and advice. Lots of things in anxiety disorder treatment to consider, and all of them good. But the key is they take a long, long time. You've got to hang in there with people and advise them and reassure them about these timeframes. Cognitive behaviour therapy, including the many available now, digitally applied cognitive behaviour therapy, they're good. They have evidence. We'll come to that in a minute. Medication is good. There's evidence for it. They work. Lifestyle factors, evidence for it. They work. And a whole range of other resources besides to help people and their families understand better and manage better. So cognitive behaviour therapy works well. Very strong evidence base. Very well studied. Very many component strategies, but often looking at things like managing arousal, those physiological symptoms of anxiety, looking at things like graded exposure, inhibition of these abnormal safety responses and fear responses, and developing a whole range of other cognitive strategies to help people deal with, one, their symptoms, and two, the situations that contribute to or cause their symptoms. Cognitive behaviour therapy in this group, which are often very chronically unwell by the time to get to treatment, provides 50% of people with significant symptom relief. That's a big step. That doesn't match the kind of often quoted figure of 70% of people that are given antidepressants for depression get some significant relief, but it's significant. And when you combine it with medication, of course, it's even more significant. It can be delivered fairly flexibly. Face-to-face cognitive behaviour therapy in the standard consultation has been very well studied over time, either in individual one-on-one consultations or in small group-based delivery. There's strong evidence for effectiveness in both styles. The more readily available in the last 10 to 20 years, digitally applied, if you like, cognitive behaviour therapy via computer, tablet or phone have become very popular. They've grown in number. Some of them are free and some are cheap and some are slightly more expensive. And there are a range of books out there, of course, written mostly by Americans, mostly available on Angus and Robertson and places like that and other bookshops. A lot of CBT-based books that have a sort of self-help ethos dealing with anxiety and other related symptoms. Digitally delivered cognitive behaviour therapy has not been as well studied as face-to-face methods, but probably is just as effective from some of the research that has been done. It's certainly cheaper, certainly more available. You don't have to wait 6 weeks for a first appointment. You can do the appointments in your time. You can do them at a speed that might be suitable for you. So they have all the flexibility of any digitally applied technology. The books, of which there are many, and every bookshop has lots in the sort of self-help and personal growth section, not really been assessed for effectiveness. They probably don't hurt. They probably assist in the sort of more on the psychoeducation side of things, people learning more and understanding about their symptoms, and probably pads out treatment generally. I do get a lot of people coming to me and say, oh, this book's fantastic. And no one ever has the same book. It's always some different book, some different. And people often give them to me as well after they've finished. So I've got a whole end of them in my bookshelf. And they're all different, but they all have the same sort of ethos. They're all written by well-meaning American people. Some of them appeared on Opera's book show as a book of the week. But they do have this sort of motivational style of influence and this sort of psychoeducational input, which I think is really useful. So I often say to people, go out and buy a book. I don't care which one, just go and find one. They'll go off to the bookshop and have a look around. They'll read through a few and they'll buy something. And they'll feel motivated and they'll feel like they've taken an active step for themselves as well. And I think that sort of self-actualization is really important. I tend to refer mostly in my practice to clinical psychologists who practice mostly in face-to-face settings rather than digitally. I work in Hollywood. There's a plethora of clinical psychologists within 10 kilometres. Many of them have been busier since COVID, but the wait times aren't particularly long. And I think that human interaction, face-to-face, in the same room, and everything biologically that comes with humans interacting face-to-face is really important for them. However, some patients say, look, I really prefer the online alternatives. They're really good for all the reasons I've outlined previously. And I don't think it really matters. I think if you are under 45, you're probably going to be better at the online alternatives. If you're a little bit older, you might prefer the more traditional methods. But I'm still pleasantly surprised by people in their 70s who are very digitally switched on. And equally, you sometimes meet people who are much younger who aren't. And so you need to obviously discuss the alternatives with your patients. They'll make their own choice. Clearly, cognitive behaviour therapy face-to-face is a bit more expensive. And with a recent winding back of the Medicare payments for clinical psychology, it does make it a little bit harder for some people on low incomes. So what do all these things do? They help, again, digitally applied platforms help people to recognise their entrenched, maintaining dysfunctional thought processes and their emotions and behaviours that typically their disorder, and it can be done for the same as for face-to-face therapy. Both platforms have repeated and more gradually complex challenges. Probably you're a little bit more held to account if you're seeing someone face-to-face in the same room for your appointments. Most CBT are digital or face-to-face, it's weekly or fortnightly, but again, in the digital realm, you can be a little bit more flexible. And there are a whole range of tasks that people have to apply, which just applies to both digital or face-to-face cognitive behaviour therapy. People testing themselves out and gradually exposing themselves to the feared stimuli for their anxiety disorders. There is some evidence that if you combine digital platforms of cognitive behaviour therapy with some form of person who actually keeps you honest and checks on you from time to time, the outcomes are actually better. There's a whole range of resources online, eCouch, Mood Gym, our own CCI, which are here in Western Australia. It's not a video or a connected platform, but certainly the range of information on the CCI website, which is available for free download and printing, is enormous. There are patient workbooks that they use during their group programs. Obviously, that's a free service too. I refer many patients to CCI, not because they're free, but because they're good. They're a CBT-based group of psychologists employed by the Department of Health based in James Street in Northbridge, where they've been forever. And they run extremely good programs, particularly in the realm of anxiety disorders and bipolar disorders, I might say, and also increasingly in eating disorders as well. There's a range of resources. All we have to do is Google CBT for anxiety online, and there's so much there. And some are free and some cost a bit of money, but it's generally cheaper than a face-to-face consultation. And people do appreciate the ability to do these things at home too, you know, in their evenings, in their weekends, so they've got a bit of spare time, unhurried, unrushed, good for anxiety prone people. But what about the risks? There's probably no risk, really, if you're conducting face-to-face consultations with an experienced clinician who judges the speed or the type of therapy or tailors it to the patient's needs. You're probably not going to have any risk. But if it's poorly done or the practitioner's inexperienced, it's probably a waste of time and money. And if the person thinks they're not getting anywhere or thinks the therapist doesn't get them or they're not engaged with the online platform, they stop doing it. And avoidance, of course, is part of the anxiety syndrome. So, you know, dropping out of therapy is pretty common. So that's a real skill for the therapist. Or you've got to choose your patients for the online platforms pretty well, the ones that sort of seem a little bit more motivated. And of course, being exposed to a feared stimulus that triggers your anxiety may actually increase your distress. Now, if that's not planned for, talked about, warned about, people may experience a flare of their anxiety, and that's it. Avoidance is their key. They avoid it, they stop going, they stop doing it, and then back to square one. Not only that, but they may actually then think, I'm not going to do this again. But mind you, the dropout rates in CBT, even properly applied, are about the same as the dropout rates in pharmacotherapy. So, you know, I don't think it's you know, all of these things have their failure rates. But I say in pharmacotherapy, it's really good, but you warn the patient to be patient because these are slow, there's a slow moving feast of treatment. Nothing in anxiety disorders happens quickly. You have to set the expectation. It's really, really slow. It takes months and months to get optimal dosing of medications or finding medications that people can tolerate and or seeing that kind of stable symptom reduction that we're looking for. The dosages of conventional medications in anxiety disorders are much higher than what we'd use in major depressive disorder, for instance. So titration takes longer. Of course, you also have to start lower, and I'll come to that in a minute, in dose. So things take a really long time. You really have to set this expectation that this is something that we're not really going to assess over a week or two. We're going to assess it over 2 or 3 months, and we're going to have to check in regularly. I'm going to have to adjust the dose slowly. The best results, of course, and all the studies show that good CBT alone or good pharmacotherapy alone have good results, but in 1 to 2, you get much better results. And not only in the acute phase, but also in the longer term maintenance of recovery. If medications work, don't stop them. People still commonly make that mistake when they feel a bit better. I'll be right now, I'll stop their medication. And usually what they do is they stop their serotonin antidepressant quickly. They suffer a serotonin withdrawal or discontinuation syndrome, often with increased anxiety and insomnia, and they relapse really quickly. Their vulnerability is always there. There's not been a lot of study looking at long-term treatment with pharmacotherapy over years, but the anecdotal and the clinical experience is that people need to keep taking them for relapse prevention. And of course, in depressive disorders, antidepressants are probably more effective at preventing the future relapses than they are at treating the established depressive episode in front of you at the time. As I said, not much research in long-term, you know, decades-long treatment, but there's a lot of clinical experience in decades-long treatment. Some people get the idea somewhere that this is something medication you just take occasionally or on ad hoc basis or sort of PRN, but thankfully people are a little bit better informed these days, but every now and then you find people who say, oh no, I've just been taking it when I feel like it, and you think, how did you get that message? But it's just one of those sort of almost culturally bound ideas that some people seem to have. What are they good at? Well, they're easy to start, they're widely available, they're cheap, there's pretty good quality medications around, although I would caution people about some generic brands, and I would caution my patients about changing brands during the course of treatment. I'm not sure if you're aware, but TGA allows a 20% variation in stated dose. So if something says 20 milligrams, it can be anywhere between 16 and 24. Cheap medications are made cheap for a reason. They often have no film coating or different preservatives and different fillers. I suspect they have a different quality control. TGA doesn't do a lot of independent assays of the quality of certain medications. So if you're on a brand and it works, stick to it. I've seen a lot of people with anxiety disorders switch brands and relapse, or switch brands and get significant side effects. And I think absorption rates and other things can be quite different, as well as the actual stated dose being different. So which ones? I say here, we all know the answer, including the patients. The patients come in and saying, I want to be on sertraline or something like that. And they're actually right. In fact, they're all right because all the SSRIs are about the same. So if someone says, I want to come in and I want to go on sertraline, I would say, yeah, okay, sure. But I would also come back and explain why that's a useful thing, just to give them the background. So their first line for all of these sort of, this narrow band of, if you like, anxiety disorders I'm talking about, there are lots of randomized control trials and it defeats placebo every time. The evidence is incontrovertible. I mean, you know, these are medications that are called antidepressants that are far better at treating anxiety disorders than they are treating depressive disorders. Serotonin antidepressants are probably misnamed. They should be called serotonin anti-anxiety agents, really. In a sense, I think that the antidepressant effects are almost secondary or second line. And I'm talking about serotonin antidepressants in particular. They're safe. They have a very low misuse potential, but I have seen one case of someone who went doctor shopping for serotonin antidepressants and was on massive quantities, and it was very difficult to actually determine why, what the benefit was. But they are safe, they have very low misuse potentials. There's obviously a few interactions with other medications, but not many. And if you wait long enough, a bit like psychological therapy, about half will get a benefit of significance eventually. And as I said, any serotonin antidepressant really. And I said, often the patient chooses, and that's okay. I often get people come to me and say, oh, I've got a, you know, my friend is on Lexapro. And you say, yeah, I'll prescribe that. And you write escitalopram on the script. And I go, oh, no, that's not the one I want. I want Lexapro. Yeah, oh, sure. Okay, Lexapro. They're not wrong, but it's nice to meet their expectation. And I said, well, it's going to cost you a few dollars more. Okay, that's okay. And so no one medication is consistently superior across large populations that have been researched. But of course, individuals vary enormously. And so no individual is an average, and individuals can have markedly different responses within the same class, or markedly different side effects within the same class of antidepressant. But many of us have familiar drugs as our favourites, the things that we know well, we prescribe often, we've used them in multiple different people, so we get wide from experience. Why not choose one of those? If someone doesn't have a preference, go with what you know. And if someone's had something before that's worked, use it, obviously. No point changing something that probably worked, because they will work again, and they'll work again, and they'll work again. They may change in effectiveness generally as a class. Serotonin antidepressants in older people, they tend to work less well in older people. And I say older, I mean, you know, over 65s or so. But generally, the response is consistent every time you take it. Starting medication, I say it's a bit like a 10-kilometre run if you're not very fit. You've got to start easy. And then you sort of get into your stride and you kind of get going in the middle stages. Then you try and maintain your pace and get to the end and finish with a flourish. So the dosages we use, of course, and you're probably all aware of this, are half the starting dose of antidepressant when we're using it to treat depression. So sertraline would be 25, escitalopram might be 5. Fluoxetine could be 10 milligrams. It's trying to avoid that early activation, which can be damaging to people's ability to keep on their medication, particularly when they suffer from anxiety disorder. Those activation symptoms are the first week or two. You say to people, first week or two, we're going to get side effects, no benefits. So just hang in there, stick it out. Start low to try and minimize that. Once those side effects have settled, then you might increase your dose, and then you come back and see me in 4 weeks. So by that stage, you'll be on 50 milligrams of sertraline, 20 milligrams of fluoxetine. And I tell them, but that's only the start. That's not going to get you treated. It's not going to get you under control. And many people will need a benzodiazepine in that first week or two, because that sort of activation can be subtle restlessness, unease, and insomnia. And in the second week, usually the activation symptoms or side effects start to settle, and then we can increase the dose. And of course, even the under 20 group, there's that kind of long-standing theme, which we've known about since fluoxetine came out in 1990, that's a group of people that do tend to get this transient suicidal ideation increase in the first week or two of starting these medications. And that's something we still have to warn younger people, but I tend to warn nearly everyone anyway. Just say, look, you may feel like this. It doesn't translate into a greater risk of suicide, but it is a greater risk of a distressing symptom that they may worry about, and of course their family may. And then it's all about ongoing dose adjustments. And I say, well, that's more like a walked marathon. So walking a marathon, it's not a fun run anymore. It takes a long time. And eventually you get to the end and you feel really satisfied, you've achieved something, and you forget about the blisters that came with it. But so this is a very long-term approach. Regular reviews about every 4 weeks, likely regular dosage titration upwards. And we are using higher doses of these agents. And it could take several months. And you become like the coach. Reviewing progress, reassuring every step of the way, talking again about the long time frames, reminding people, and then planning the next step. Obviously, CBT should be happening at the same time. And we're also setting, of course, as I've mentioned a few times, a modest reduction of symptoms as our target. But as I said earlier too, that even modest reduction in anxiety disorders is something that people are very appreciative of and translates into often more significant gains in functioning. So every dose requires some sort of acclimatization. As we probably know, people with panic disorder in particular are very aware of their physical symptoms, very concerned by them. So we need to educate them about that all the way from the start, and what the side effects mean, and that they're early effects generally, they subside with time. And then we start scaling the mountain. So we're going very Everest-like. They're getting acclimatized at base camp with 5 milligrams of escitalopram, and then we're seeing them every 4 weeks and going camp 2, 3, 4, 5 to the summit. And at the peak, i.e. the summit, there's a little bit of euphoria that people are doing better. And then it's a focus on them learning how to survive again, how to function again, how to do things they've been avoiding for a while, how to get the confidence to go back to the workplace because they've been so socially anxious, they've been allowed to work from home, or to have the confidence to go on their own to the supermarket, or have the confidence to stand up and give a presentation. At the peak, dosages are pretty high. They're higher than what we use, and you know, as I said, not effective in depression really, but more effective in anxiety, in my opinion. But the dosages are higher too, and often surprisingly well tolerated. I've never had that explained to me why. But very high doses sometimes with slow dose titration for this longer-term maintenance period. Other agents, and I've got the last few slides now. So there's a whole range of other things. I said the other agents are like the Old Gold and the Moro chocolates in the box of Cadbury favourites. No one likes them. They're always left till the end. And if you come in at the end, that's all you got. But sometimes that's nice to have a little bit of chocolate. So tricyclics, they do work. But all the usual issues with tricyclics around side effects and tolerability and toxicity and overdose. When they are used, they're often used too low a dose anyway because of side effects, and therefore you've got a catch-22. You're using something because of the side effects are not really working, but people keep taking it and they don't get anywhere. But they can be useful. Monoamine oxidase, as I said there, no psychiatrist under the age of 70 knows how to use them. I prescribed monooxidase inhibitors once in my entire 20-year career. So, you know, they're just drugs that have sort of been forgotten, unfortunately. They are useful, but with the Australian diet, which is so much more Mediterranean influences these days, they're a tricky thing to do. The dietary restrictions are really, really rigorous. My one patient I did study on monoamine oxidase inhibitor had a hypotensive crisis from eating a hamburger at McDonald's that had tomato sauce and pickles in it, and that kind of cheese-like substance they put in their burgers. So it doesn't take much. Doesn't take much to have a hypotensive crisis and suffer a lacuna infarct, unfortunately. Meclobamide, it depends whether you think it's effective for anything or not, but not much useful evidence to suggest it's useful. And a few other agents. I know mirtazapine and agomelatine are used a lot in general practice. You see a wider variety of mood and anxiety disorders that I would see. They're often really useful agents. Agomelatine, because its tolerability is so good. Mirtazapine, because it assists sleep and anxiety. They haven't been well studied. Agomelatine, there's some evidence now, and of course, the manufacturers promote it quite heavily in anxiety disorders. Perhaps I suppose in this cohort that I see, much more severe, haven't seen a great deal of benefit, but in a lower severity cohort that you might see in general practice, yes, it's probably a wider role. Switching antidepressants can be tricky. Serotonin agents in particular have withdrawal effects or discontinuation syndromes. You've got to be very careful about that. The worst ones are paroxetine, escitalopram, and don't talk about SNRIs, desvenlafaxine. All of those things, people call them brain zaps. Everyone calls them brain zaps, even if they've never heard that term before. Fluoxetine doesn't, very long half-life, it's easy to taper off. But, you know, you've got to be careful when you're swapping one SSRI to another. And there's a lot of algorithms out there online that explain how you might do it. Most of them are pretty easy. Actually, you just taper down one, and before you stop it, you've tapered up the other and do a cross taper. Things like fluoxetine, very long half-life, you need to let it bleed out a little bit. Benzodiazepines, not the big bad wolf, but they can still bite because they're very effective. They've been around for, I don't know, 70 years. They're very anxiolytic in the short term, but of course therein lies the rub. Then people really want them, and they're not that great in the longer term. A lot of adverse side effects, a lot of issues with tolerance and abuse and withdrawal effects. But most of the time, if you choose your patients wisely, benzodiazepines can be used quite successfully. And of course, everyone puts in a bit of restrictions about quantity and dispensing intervals between repeats and things like that. They're kind of good safety measures. Not the first line of treatment, but still have a place. A few favourites of mine in the acute setting in our hospital. We use lorazepam a lot. I think it can be used safely outside of hospital too. Just the 1 milligram tablets, half of one. Just a small prescription, very useful. As I say to people, if you use it once or twice a week, you can use it forever. But if you use it every day, you'll be in trouble in a few weeks. And then no one will prescribe it for you. And then you'll have an acute withdrawal. I warn people that can be very dangerous. It seems to work with most people if they're not addiction prone. Trying to sort out who's addiction prone and who isn't is often a bit tricky because people don't tell you the whole story, but generally get it right. Clonazepam, one of my favourite drugs, and I don't know if any of you have seen some letters from me, but clonazepam is a greatly underprescribed drug in psychiatry. It's used in epilepsy, and everyone thinks that's great. But as soon as it's used in psychiatry, everyone thinks that's addiction, or it's drug abuse, or it's erratic prescribing, or it's the same drug. It's a very long half-life benzodiazepine. It's very cheap as a private script. There's 3 or 4 good studies comparing it to SSRIs for which it was superior short, medium, and long term. It's very tolerable. The sedative side effects diminish quite quickly. The benefits tend to be maintained. The longest I've had anyone clonazepam is 19 years, and the dose hasn't changed in 19 years. So it's got a low potential for euphoria or abuse. However, saying that, there is always someone who will over-medicate. You can't say it's 100% safe. But it's been a long half-life. It's easier to withdraw if necessary. I use stable doses, particularly in bipolar disorder with comorbid anxiety, which is very difficult to treat, often very low doses. And they don't change. They stay like that for years and years and years and years and years. And they're effective over the longer term. So clonazepam is a good drug. I know in general practice, you see all these people wanting benzodiazepines. It makes you wary. You have to have your bullshit detectors on all the time, I imagine. And I know it's a very good reason. You're very often very reluctant to prescribe benzodiazepines, and I think it's a very good thing. But I'm just making a little bit of a case for clonazepam here. Obviously, lifestyle issues, illicit drugs. Cannabis worries me a lot. Medicinal cannabis worries me a bit. I've seen a few people on medicinal THC preparations who are clearly worse, who claim that they are better. I'm not sure why 30% of prescriptions go to young men aged 18 to 30. What does it say about prescribing and the need for cannabis and what it's been used for? CBD, not as worrisome to me. I have seen a few cases of people with predominantly cannabidiol products who do quite well. I can't say I'm an expert in the area at all, but most of my patients who I do refer to, for instance, Emerald clinics, a very small percentage continue their treatment. I think cost is one of those things too. It's surprisingly costly. Alcohol, far more toxic than we realise. Even a small amount of alcohol is very toxic in anxiety disorders. Even small amounts of alcohol at night are potential risk factors for the generation of anxiety disorders the next day. Sleep hygiene is terrible in everybody these days. There's too many things that interfere with sleep and good sleep hygiene. That's a very hard thing to tackle. Even in our psychiatry ward, people come in and the nurses check on them, they're on their phone at midnight. The next day they can't sleep. That's their complaint. Then they want a sleeping tablet. Sleep hygiene, we have to work on it. We can't seem to shift people. It's too stimulating, our electronic devices. And exercise, often neglected in this group too, or avoided. People often prefer a pill anyway. But very short periods of vigorous aerobic and resistance training every day is extremely effective for a whole range of things. And I only talk about 30 minutes. And I say that's kind of like that sort of F45 style exercise, multi-station, a little bit of aerobic, a little bit of resistance. So in summary, on a PowerPoint slide, it's really easy, actually. You can just sort of say, yeah, that's what you need to do. Recognise the disorder, engage the patient, educate, lifestyle advice. Talk about this really, really long time frames. And I think it's probably the longer, it's the main point I can make today. Small gains, slowly, with frequent check-in and frequent adjustment of medication dose. You're managing over a very long term. Get the cognitive behaviour therapy going early, and if it's online, great. The medication takes much longer, comes in over the top to add to it later. And the medication is a slow but increasing tempo that requires a lot of attention and quite a few consultations besides. And I think that's it. Yes. Thank you.
Thank you very much. We are running a little bit late. We've got lunch out there. Now, there are one very quick questions. No, all right, you're sticking around for lunch.
Yeah.
Excellent. Just one quick word. Leighton did mention availability of clinical psychologists. There are now 3 Ramsay psychology centres just opened in Perth, Joondalup, West Perth, and Mount Pleasant. New clinical psychologists there with good availability, so we'll look those up. I'm sure we'll find somebody to help support the patient's treatment. Thank you. We'll see you at 1 o'clock for the final section of the day.